if we've got time, I'll go through those, but they may come up anyway in the chat. And I think there's lots of opportunities to ask questions and have those chats as well. And that's part of the discussion. Okay, so if we think about asthma and how we've been managing asthma, it's changed very much over the years. So if you go back to the 1970s, asthma was really seen to be bronchospasm. Okay, so it was very much the smooth muscles were bronchoconstricting, and patients were therefore having wheeze and were short of breath. It wasn't really until the 1980s that we started to know that inflammation was also going on the epithelium of the airways. And we went on then to know that if we didn't control the epithelium, that inflammation, you then actually got collagen being pushed underneath the epithelium, and you started to have remodeling of the airways, and the basement membrane of the airway became very fixed and very rigid. And what we then started to know that the inflammation was very much being caused by eosinophils, and lots of different processes going on in that whole sort of inflammation processes. But what I would say is probably our management of asthma hasn't kept up with the science. And although we've had guidelines produced, directing us and telling us what treatments we should be used, I think for too long now we've over-relied and thought of asthma much more about bronchospasm, and therefore the salbutamol and the terbutaline, the short-acting beta-2 agonists, have been the sort of the main treatment, not necessarily in our eyes, but certainly within our patients' eyes. And we all know our patients who over rely on their salbutamol inhalers. But we mustn't forget that actually when salbutamol and other beta-2 agonists were first launched, and particularly isoprenaline and phenterol, which are sort of highly full agonists within the beta-2 receptor, and these were launched at the end of the sort of the 1970s, early 80s. And this is a study that was in New Zealand, and they looked at trends in asthma mortality of between 5 and 34-year-olds when the introduction of isoprenaline and phenterol were introduced in New Zealand. And you could see the peak in mortality around that time. Now, salbutamol came out in 1969, and there wasn't such a big peak in mortality around that time. But don't forget, we've also had the SMART study in America that looked at salmeterol being prescribed on its own without an inhaled corticosteroid, and showed there was an increased risk of mortality. And that's when the MHRA produced a document saying that long-acting beta-2 agonists shouldn't be prescribed without an inhaled corticosteroid. More recently, we've got more data. So the Sabrina program is a very large study across the whole of Europe. So, includes about 5 countries across Europe. And again, it looked at the use of salbutamol inhalers and what influence that had on mortality. And if you look on the graph on the left, you can see this blue line here is where patients are collecting more than 11 canisters of salbutamol in a 12-month period, compared to the black line where they collect between 0 to 2 canisters of salbutamol in a 12-month period. And you can see the sharp decline in the blue line is indicating an increase in mortality from overusing or over-relying on the short-acting beta-2 agonists. And of course, all of you, if you haven't seen me talk since 2014, I still mention the National Review of Asthma Deaths that came out at that time, because it is still very pertinent to today. But the NRAD report showed that we were having 80% suboptimal prescribing of preventers. These are in people that died during that year that it was being investigated. 39% of patients collected more than 12 SABA inhalers in that 12-month period. And there was also people dying that were still on LABA monotherapy. So we started to see again this pattern of over-reliance on SABAs and under-reliance on inhaled corticosteroids. And we know that with SABA prescribing, a lot of our patients develop beta-2 receptor tolerance. They get heightened, so the airways become even more twitchy because salbutamol is not calming down the inflammation within the airways. You actually get an increase in inflammation caused by the eosinophils in the airways, as well as things that we all get taught about at pharmacy college, university, like hyperkalemia, tachycardia, increase in anxiety, and also a lot of patients tremor, but they also get this cramp in it, they're locking. And salbutamol is not a very effective in many ways. It's a partial agonist and it has a very, very flat dose response curve. So you don't need a lot of dose of salbutamol before you fill all those receptors, and you could just keep on giving more and more and more, but the patient actually doesn't get any further benefit. Unlike probably formoterol, which is we use a lot as a long-acting beta-2 agonist, has a much better dose response curve. And one of the things that Sabrina study that I mentioned a moment ago showed us was that actually we're pretty pants in the UK. Sorry, that's probably not a very technical term to use, is it? Apologies for that. But we're not very good in the UK in terms of our salbutamol overprescribing. So if you go here, Italy, 91% of their patients with mild and nearly moderate asthma are using between 0 to 2% of the SABA inhalers. We're at 42%. That's a massive difference to like Italy. Even if you look at Germany, Spain, Sweden, not perhaps quite so good, but the UK really slightly better for our mild asthmatics, but really our moderate is not very good at all. And we are very much overusing our SABAs if you look at the 3 to 6, 7 to 12, or the greater than 13. So the UK, I'm going to say it again, is pretty pants. Okay. So the challenge is people with mild asthma can still have severe or even fatal exacerbations. And that's probably because they are not using the correct medication. Patients who are treated with SABA monotherapy have a much greater risk of severe exacerbations and mortality than patients that are on inhaled corticosteroids, which actually makes a lot of sense because it's the inhaled corticosteroids which is reducing inflammation and really treating the asthma. The SABA is just treating the symptoms, and what we need to do is get to the bottom of actually treating the asthma. It's a bit like treating a diabetic and not giving them insulin, but just giving them, glucagon every now and again for when their blood sugars go up, or an angina patient, just keep giving them GTN spray, but not give them the preventative treatment. And we don't do that at all in cardiology or diabetes. Over-reliance also can cause a lot of those other problems I said. So it means that patients are more likely to have inflammation, the airways are more twitchy, and they will get a heightened exposure and response to exposure to triggers in the future as well. And you get this long-term decrease really in SABA effectiveness as well. But again, all our patients, they love their blue inhaler, and this is one of the challenges we need to try and stop our patients doing it. And I know that a lot of your patients will be coming in wanting emergency supplies when they've run out of their salbutamol inhaler. So it goes back to what we're trying to treat now, and this is trying to treat this inflammation, and this is where the eosinophil comes in. Now, in the interest of time, I'm not going to go through a lot about the eosinophil, but we know that the eosinophil is part of our immune system. It's because of the parasite infections. That's why we have eosinophils. And I love these pictures here. These are all eosinophils surrounding a worm, and that's what it's used to fight and get rid of worm infections. But in people with allergy and atopy, we don't really understand why, but eosinophils are being produced from the bone marrow. Levels go up. They are migrating around the blood vessels. They've got no worms to sort of try and fight and get rid of. So they travel to target tissues in the body, and the lung is one of them. Once they're in the lung, they release lots of chemicals and cause a lot of the inflammation in the airways. So this is what asthma now looks like in terms of all the different pathways that are undergoing within asthma, and we've got very fancy drugs now to treat some of these different pathways, but ultimately it's the eosinophil which is key for the vast majority of people with asthma. And 85% of people with asthma, if we can manage and stop the eosinophils from getting into the airways with inhaled corticosteroids, we can actually dampen down inflammation, stop the remodeling, and prevent exacerbations and symptoms for our people with asthma. This is why we needed to change the asthma guidelines. And a couple of years ago, GINA, which is a global international guideline, produced this, okay? And it says salbutamol does not treat asthma inflammation. Salbutamol monotherapy should not be prescribed. All adults should be inhaled corticosteroid containing therapy. Overuse of SABA relievers is common and associated with poorer asthma outcomes. So within Leicestershire, we knew there was a potentially going to be new NICE guidance being produced. So NICE, SIGN, BTS, British Thoracic Society, are all now joined together. The draft guidance came out in June and should be published at the end of November, but we didn't want to wait. And so we decided to pull our guidelines together. I was having a little bit of sort of palpitations thinking, what happens if it's completely different to what NICE and bring out? But luckily, we're on the ball, and our guidelines are very much in keeping with the new NICE guidance. Well, the draft NICE guidance, but I don't think it's going to be changing too much. So this is what the guidelines look like. These are available on the APC website. So if you go onto the LLR APC, Google that, put in asthma guidelines. Remember, there's lots of resources on there for people with respiratory disease to support you. I just want to talk you through what the changes are. So again, this is adults. They have to have a diagnosis of asthma. I know that sounds silly, but a lot of our patients, unfortunately, have not had objective testing for their asthma and have a positive formalized diagnosis. So we do need to be mindful of that. So the flexible regime, and this is really where we're going. So we're saying now we shouldn't really be prescribing salbutamol to our patients with asthma. What we're going to be doing is initiating an ICS, so either budesonide or beclomethasone, with formoterol. Formoterol is a long-acting beta-2 agonist, but it works as quickly as salbutamol within 3 to 5 minutes. But it obviously lasts longer. It lasts for 12 hours, but it's got a good dose response curve. So you can go up to 72 micrograms in a day. So for people with very, very mild disease, and these are probably some of your seasonal patients you see, they're having asthma symptoms sort of twice a month or about that, then you would actually see them on an ICS labber. And the first line we're recommending is Fobumix, 160, 4.5, Easyhaler to use one dose when required. If patients can't or for some reason don't like the Easyhaler, then we've got the Foster Nexthaler and the Symbicort Turbohaler as an alternative. We are promoting dry powder inhalers because most people actually can use dry powders, and the majority of people that use MDIs without a spacer breathe in far too quickly and it hits the back of the throat and it doesn't get into the airways. Most patients can use a dry powder and can breathe in, but if they won't, and this is about the patient and we must prescribe according to what the patient is good, then we have Lufabec, which is now the generic for Foster, the 106 one dose PRM. So that's simple. So these are sort of patients you would have seen that were on salbutamol, but salbutamol, when they did get symptoms, didn't treat the asthma. Now we've got a drug which actually gives them the hit of salbutamol, so their symptoms are controlled, but they also get like a shot of ICS, which helps to dampen down that inflammation at that time. Okay, and there's lots of studies to show that it reduces exacerbations. And in the interest of time, I'm going to scoot over these, but if you're interested, the Sigma 1, Sigma 2 papers that look at this approach in managing as needed ICS formoterol for mild asthma. And if you do it, you actually get a better outcomes and actually less inhaled steroids than putting people onto regular BD dosing. But it is for only very mild people. Okay, so if patients have had exacerbations of asthma, had hospital admissions, have had sort of courses of oral steroids, are symptomatic, waking with asthma once a week, or having symptoms sort of more than twice a month, then you go on to the maintenance. Now, all of you probably are aware of maintenance and reliever therapy. MART therapy used to be called SMART therapy when it was Symbicort. That's exactly what we're doing here, but we're now promoting it much more than we did before. So again, it just is so simple because you put someone onto Fobumix 164.5. You start with one dose twice a day. They can also use one dose when required. And there's some guidance at the bottom here that usually more than 8 doses isn't required, but if necessary, they could go up into 12 in a day. But you wouldn't want them to be on that for long periods of time, and that would just be for a few days before they step down. And that's be how you would start. You've still got the Lufabet there as a backup, and you've got alternative dry powders. If that didn't control their asthma, then you could move up to 2 doses twice a day. Okay, and remember, you move up and you get control, and then you step back down again, and that's very important as well. So the reason why MART therapy works is because before someone has a full-blown exacerbation, you've got this wonderful window of opportunity. Because what tends to happen at that time, inflammation in the lungs goes up. So that's eosinophils start going to the target organ of the lungs and start causing, having a party and causing inflammation within the airways. You start to see patients peak flow drop. You start to see them having nighttime symptoms, cough, wheeze, and traditionally puffing away on their salbutamol inhaler, which just escalates all of this and doesn't solve the problem. And the patient then either luckily gets through it or they end up on oral steroids because they need to be treated for an exacerbation. So if we at that early opportunity give them that shot of inhaled corticosteroid, you start to dampen it down. So patients increase the ICS according to the level of inflammation in their lungs. Hopefully that stops them going on to have oral steroids, which are so detrimental to our patients in terms of side effects, and we can stop them going to that level. And then once they're controlled, they automatically, as part of their PRN use, will put their ICS dose back down again. And this is very, very effective treatment. And, again, lots and lots of studies. I'm not going to go into this in huge detail, but, MART has a great effect. Formoterol also has an effect, and it's much more effective than the ICS LABA. Okay. Part of this is going to be us convincing our patients to get rid of the salbutamol, because what we don't want is patients to be on MART and then have sort of stockpiled salbutamol at home, or sort of sharing between families or going to different people to get different salbutamol, because that's their security blanket, that's their safety net. So as I said, this is sort of pathway moving up and down, and it is really, really straightforward. Now, if people can't be managed on medium dose of ICS LABA, which are these doses here, then really those patients are the ones that you start to look at referring through to secondary care for assessment before we put them onto higher doses. But we could perhaps add in Montelukast, we could add in Spiriva Respimat at that time, but certainly we're starting to think about more severe patients. Majority of our patients, 85% of asthma patients with asthma, strangely enough, can be managed at this stage of the guideline. Okay, so the 15% you're starting going on to high doses of inhaled corticosteroids and or sort of injections then for the asthma. However, there are some patients that won't like this approach. So within the guideline, we have kept a more traditional stance, okay? And this is where you would start with the regular low dose ICS and you would have a SABA. But what we're trying to promote again is using dry powder inhalers. But you have got the old options there, which we're so used to seeing, of Qvar and Salamol in the background there. And of course, it still is a step up and step down according to symptoms. But there is that more traditional approach, if you're not quite sure where the patients are, but we are trying to encourage people to establish where the patients are and then to change them over to that flexible approach, because it will work well for our patients. There's lots of information in the guidelines as well around sort of responsibilities, indications of uncontrolled asthma, responsibilities of primary, secondary, and severe asthma services, and that's just there for reference on the back of the guidelines, as well as sort of some information about prescribing and where to find out more information. The reason we have gone for a lot of dry powders is obviously because of the environment. So I very much use a lot of dry powders in my practice because I find that patients have a very good inhaler technique with dry powders. And as I said, so many of our patients with MDIs, because the MDI is pushing the drug out at 60 miles an hour, they breathe in with a high inspiratory flow because there's no resistance in the device. It just impacts on the back of the throat, and very little of the drug actually gets into the airways. Whereas the dry powders, which are been developed, I mean, the MDI came out in the 1950s. The dry powders are being developed with the technology to ensure that patients have the right inspiratory flow and to optimize lung deposition. Of course, the propellants, the MDIs, the autohalers, the easy breathes, they've all got propellants in them, HFA 134A or 227, but we don't use a lot of that in Leicestershire. And they are having this impact on climate change. So we are trying to move away from MDIs. Okay, so these ones at the top here are the ones with this is the kilogram of carbon. And you would have seen that's, one canister of Ventolin is 28 grams of carbon. It's equivalent to driving 175 miles from London to Sheffield, compared to some of the dry powder inhalers, which is probably equivalent to driving 4 miles. So massive difference between dry powder inhalers and MDIs. So, hence why we're trying to encourage prescribers to use dry powder inhalers for our patients. And this is really the medicine optimization. There's a framework for primary care as part of it's the MOF framework to encourage dry powder prescribing. This is a national initiative. Leicestershire aren't doing particularly well, so we're trying to push the use of dry powders more. So dry powders now are first line where clinically appropriate. We would like to try and align as much as we can to the guidelines, particularly the asthma guidelines, because you'll use less inhaler devices if you use the flexible approach. Our first line choice is Fobumix Easyhaler, and that's the most cost effective and easiest device for people to use and to carry around. But as I said, we've got the Foster Nexthaler and the Symbicort. We do use the Foster Nexthaler for severe asthma patients, so the 206, 2 doses twice a day, because it's only one device for that patient, and we also use it to help us with adherence and monitoring our patients. Prescribing short-acting beta-2 agonists, we were trying to avoid, but where appropriate, we're trying to encourage the Easyhaler salbutamol, which is a dry powder device, rather than using the MDI. But if you do need to use the MDI, we're using Salamol rather than using Ventolin, and the Easy Chamber should be given to patients who are on MDIs. I did want to just bring out, I'm just conscious of time, but I just want to bring out another initiative that we've got across Leicestershire, and this is the Eclipse Boomerang. And this is actually where patients are being asked what they feel about the environment. This is patients who are on Foster 106. They're not under a respiratory specialist. They've not had an emergency admission in the previous 12 months or a course of steroids, and they haven't already been asked about dry powder and not wanted it. But it's actually about putting patients first, and they're sent a lot of information and they can opt in to having a greener inhaler. Some of our patients are really passionate to try and save the environment and to potentially improve their asthma care or to stabilize their care. So patients are then being sending a note back to their GP. The switch is occurring, so they're automatically being switched from an MDI to an Easyhaler, and we are using the Fobumix Easyhaler because it's our first line choice. And then they're being told to have a new medicine service, hopefully with yourselves. And this is where I'm asking, and for your support. Obviously, the new medicine service is something that I'm sure you're very engaged with, and this is vital that patients get shown how to use these devices. So if they are coming to you, they've had this switch done by the GP practice without a face-to-face, which for me, I'm always like, no, you can't do an inhaler switch without a face-to-face. But these are very stable patients, and having that safety net of having the community pharmacy team supporting with a new medicine service certainly helps me feel a little bit more content with this service. And as I said, most people actually will probably be able to use the dry powder better than they probably have been with their MDI anyway. So this is the new formulary, the new drugs, and this is important for you to know from a stock maintenance point of view as well. So we will be seeing a lot more Fobumix Easyhaler. The Nexthaler, I think you're probably familiar with anyway, and the Turbohaler has been around for years. We would like to see a lot more of this little blue fellow on the right here, or the Salbutamol Easyhaler. We are, though, from an MDI perspective, switching from Foster MDI for Lufabec. That is a cost-saving initiative that the ICB is promoting. And we've also switched from the aero chamber to the easy chamber device, which again is just a cost-saving initiative for us, but has very similar properties. So patients shouldn't notice any difference. So, your role as community pharmacist, I hope, well, people who work with me know how supportive I am of community pharmacy in Leicestershire. The new medicine service, we are trying, where we're switching patients in hospital, to utilise the discharge medicine service, which I think is underutilised. Any support, we're sort of trying to ensure that patients aren't on MART therapy as well as SABAs, trying to discourage that sort of SABA inhaler coming back into that treatment regime, and any sort of support the patient has. And I think Amanda has lots of support materials for you and to signpost you there, which is why we're doing a bit of a double whack this evening. Our own local resources are all there for you. So please, there's lots of work that we've been doing. There's a public campaign you may have seen that we've put out around inhaler technique and the green agenda. So please, the LLR APC website is a good place to go. If you want sort of posters, things like that, then we can get those printed for if you wanted those up in your pharmacy. And that's really all I wanted to say. As I said, I've got a few sort of key questions that you might want to ask, but I think I'll stop there. I've gone through the guidelines quite rapidly, but I wanted to sort of highlight that the trying to remove the SABA, the ICS sort of formoterol approach to management, which we're calling the AIR anti-inflammatory reliever, as well as the MART maintenance and reliever therapy. So that's your flexible approach to management rather than that traditional method. And that's keeping up with the science around asthma, which is now all about the overactive immune system and dampening down that inflammation within the lungs, rather than just treating that bronchospasm, which is what we do with salbutamol. So thank you very much for listening. I'm going to stop and hand over to Amanda, and then I think, are we having questions at the end, I believe? How you want to do it, or I don't mind.
I mean, we can have questions now, maybe, if people want to just raise their hand while it might be fresh in their minds following Anna's presentation. We'll pop it in the chat, whatever you feel comfortable with. Any questions around what Anna's presented, or any of the content? You've stumped them, Anna.
Yeah. Well, one of the things, can I just answer one of my own questions, which I get here, which I hear a lot actually, and I think that's around a couple of things around switching patients from an MDI to a dry powder. And a lot of people will say, oh, I don't like it, or it doesn't work, or I don't feel it, or what have you. And that's the conversation you have there is if, because patients have been so used to a meter dose inhaler, and it often does hit the back of the throat, that is the psychological feedback that the patient gets, thinking that it's working. Okay, but we know that that's the impact on the back of the throat is reducing the lung deposition, and therefore the outcomes from the medication. The thing with dry powders is you don't get that feedback. You don't have that sort of hitting the back of the throat. Some dry powders will leave a taste in the mouth. Okay, so Nexthaler, Durarest, someone's mentioned it in the chat. We're not promoting Durarest, but patients on it, it's fine. We're keeping people on it unless they're uncontrolled, and then we may switch across. But we're not changing people off Durarest, but it's just not recommended to start people on it. But Durarest leaves quite a gritty taste in the mouth, and a lot of our patients don't like it because it's quite gritty. Nexthaler leaves a sweet taste. Some people like it, some people don't. Some people think it's the drug that's stuck in the mouth, rather than just the lactose that's left behind when the drug has flown through the mouth into the lungs. Okay, and Fobumix doesn't really taste, nor does sort of Symbicort. So, the fact that they don't feel it, you've got to almost say that's a good thing, because you don't want it in the mouth or on the back of the throat. You want it actually in your airways. But I see that a lot with patients when we do the switch. The other time is like Ventolin to Salamol switch. Some people don't like the Salamol. Now that could be brand snobbery, a bit like me with tomato ketchup. You know, it has to be Heinz. I can't have Bramwells or anything like that for Heinz tomato ketchup. So some people are very snobbery, you know, brand specific. But Ventolin is very fast velocity when it comes out, so people really do feel it on the back of the throat, whereas Salamol is much slower. Now, from my perspective, a slower velocity for Salamol is good because it gives people more time to breathe in slowly and steadily and improve lung deposition. To a patient, it doesn't feel the same, and it doesn't hit the back of the throat the same, so they don't like it. If they use it with a spacer, it probably work, you know, it will work just as well, but it's that sort of psychology of working with the patient that we just have to deal with sometimes.
Thank you, Anna. There's two more questions, if that's okay. So one's by Badner Ben, just around children, asking specifically whether whether the guidelines or the guidance will be including children, and from what age, I presume.
Yeah, so I said at the beginning that this is very much for adults over 18, but the NICE guidance, the draft guidance that have come out and will be published, the expected date is the 27th of November this year, will have this flexible MART approach from the age of 12 upwards. Okay, so it's, you know, the guidelines may look differently because of licensing. It depends what the pediatric team feel comfortable with recommending, you know, if drugs are off license or what have you. So, you know, Symbicort is licensed from the age of 12 up, Durex is licensed. So the products may change, but it's likely that the pediatric team with the new guidelines will look at this flexible approach to follow the NICE guidance, but they wanted to wait until sort of NICE guidance came out. What might not be so clear is that mild asthma in the sort of adolescent population, the evidence is less clear. So the ICS formoterol, using it just PRN in that age group, isn't particularly evidence-based. What the argument from a population level is that group is very non-adherent and is likely to be non-adherent to ICS. So if you give ICS formoterol to a patient who's non-adherent, when they actually do need it, they are at least getting the inhaled steroid, which will help rather than just the SABA. So it might be included. We'll just have to wait to see when the guidance actually come out. But at the moment, the ones that are on the website are just for adults.
Thank you. And one last question from Rupal, which is, I think it's a comment, maybe a question, but I have a notice albuterol prescribed when diagnosis is not clear, for example, infection, maybe a cough or even asthma. So
yeah, Rupal, you hit the nail on the head. It's one of the frustrations that, you know, you see salbutamol being given for heart failure, for interstitial lung disease, for chest infection, for a bit of, you know, wheeze, pneumonia, these sort of things, and there's no sort of underlying diagnosis of asthma. Again, on our website, I didn't go through diagnosis today, but it's extremely important that we have a diagnosis with asthma. Asthma, unfortunately, is not simple in a sense to diagnose, because it's a bit like putting a jigsaw puzzle together. You've got to piece all the bits together to get the diagnosis. You know, so you want variable airflows. You know, you want to trigger, you may have a family history. I mean, ideally, you want to have some objective tests like a raised blood eosinophil that we could see. We might want to see a raised exhaled nitric oxide. Love to have spirometry, but that's challenging in itself. But we shouldn't be just saying that to a patient they've got asthma, and salbutamol shouldn't really be given at all. Because it's not going to work in ILD, it's not going to work in heart failure, it's not going to work for a chest infection, because it's not the beta-2 receptors which are causing the symptoms within it. If it's asthma, it may work, but it's not the treatment we want. We want those patients with asthma to be on the inhaled steroid element.
Okay, and one last question, and I will hand over to Amanda and then maybe at the end of Amanda's, I'll come back to the questions if that's
Sure.
okay.
Yeah,
So
absolutely.
one last question is to confirm, is the maximum dose of Lufrabet Foster 100 over 6, 8 puffs for MART therapy and 4 puffs for the 200 over 6?
Yep, licensing, I'm afraid to say. I mean, I guess what we've got to think about is the 206, so that's 2 puffs twice a day. That's your 4 puffs, okay? So that's the licensed dose for Lufabet Foster, and you are then at, you're right at the top of the dose response curve really for chronic treatment with ICS. You'll be starting to look at steroid cards for these patients because there is a systemic adrenal effect. So all patients on high dose inhaled corticosteroid, which that dose is, should be carrying a steroid card with them. What you're doing with MART is you are treating at a much earlier, so you're on quite a low or moderate dose, and then you're adding the extra in at the time that patients need it. Now, it's possible that they are probably getting a little bit of systemic absorption at that time, but it's only for a short period of time. So the 12 doses that that patients could go up with Symbicort and with Fobumix, you'd only really want that for a day, 2-3 days at the most. Then you would expect someone to come back down. If it's more than that, they really need a review. And with MART and Foster, MART, and really most patients with the other two, you're looking at really 8 as your maximum. But of course, your dosing is lower. So I'm afraid a lot of it is, is licensing, but there is a bit of logic behind it as well.
Brilliant, thank you. And I know there's some more questions. Thank you, Anna. I know there's some more questions, but we will come back to them shortly. Any other questions or comments? Please do feel free to raise your hand or pop it in the chat. No, it looks like you've answered all our queries then.
That's good.
Anna and Miranda, so thank you. Someone's just re-entered as well.
Well, can I just say, I mean, if anyone does have any questions, please feel free to email me. I'll put my email address in the chat, but I think you know where I am. I'm more than happy for people to contact if they've got any issues. And we do have actually a generic respiratory pharmacy email as well, that if you want to, was set up specifically for community pharmacists to use, actually, if they've got any queries around respiratory, because the primary care can use advice and guidance, but community pharmacy can't access that service. And we have an advice and guidance service for primary care around respiratory queries and prescribing. So I'll pop that in the chat as well.
That would be great. Thank you. Well, thank you, Anna, and thank you, Amanda. Been really informative session. Hopefully our pharmacists that have joined us this evening, and also those that weren't able to, feel better equipped with the changes, and I'm sure they've started to see some of those trickle of changes, and now it kind of makes a little bit more sense to them, but more importantly, they can support their patients through those changes as well, and really just kind of propel them on that journey going forward as well. So thank you ever so much. I'm going to be on for the next minute or so, and if you can pop those links in the chat just in terms of your contact details, I think you're doing that now, that would be great. So if you want to stay on just to pick that up, you guys, before you leave, feel free to, and I will circulate the slides. I know I had a few questions around slides and presentation. The recording will be circulated shortly, hopefully by the end of the week, if not early next week. But just want to say a big thank you to both Amanda and Anna, and thank you for joining us this evening. Thank you, Anna, for doing that.
Yeah.
That's fantastic.
No, my pleasure. I enjoy it. It's a bit sad, isn't it?
No, not at all, but it really comes across that you're so passionate about what you do, and that's just lovely. Wow. That's just wonderful to see. Great. And Amanda, what a great video.
Thank you. Yeah. Isn't it just, and it's on every device as well, just by that QR code. I mean, before COVID, older person wouldn't want to get out their smartphone scanning something. That's a generalization, but I hope you know what I mean. But because of COVID and scanning and things now, it is the norm. So yeah, it's that, and it's in all of the leaflet in all those different languages.
Brilliant.
I think are the key, the key things. And I will just make sure that every pharmacy has a kit, a kit, because that's what I did in Northamptonshire, and it just really helped that it was just in the consult room, it was there, and especially because of the Boomerang project, where it is digital, and they've got that text, and they go in and say, oh, to come here, having that pack there is like perfect. I think it's just will really help. So
well, just from a practical step, just in terms of distributing those packs as well, we'll support you. So if you want to bring them in or somehow get them across to us centrally, we can then distribute them, or you can obviously send them individually to the pharmacies.
Can I do that? Can I just bring over however many 80 pack in envelopes and you
there's 224 community pharmacies, just to put that out there, so there's quite a lot.
So, right, okay, I'll definitely be driving them over to you.
Yes, and we can obviously start to distribute them over a course of, over a period of a couple of weeks.
That would be brilliant. I'll email you about that then.
Please do. Yeah.
And Anna, did I miss anything? Did you think I missed anything? Like,
no, I thought it was all great. Thank you.
Yeah,
it was quite a good double act, really. Laurie and Hardy.
I think it worked. It worked really well. I'm glad. No, it worked really well, and the feedback speaks volumes as well. Well, I don't want to keep you any longer than what you need to be here.
Thank you.
But thank you so much. Genuinely appreciate that from you both.
Yeah,
thank
nice
you
to
again.
see you both. Thanks so much for the invite. Do appreciate it. Bye.
Take care. Bye-bye. Bye-bye. Thanks everyone for joining this evening.
Good night, Rashmi.
Oh, thanks, Gareth. I didn't see you there. Thanks for joining this evening.
No problem. Good night.
Night, night. Thanks, everyone.